depending on abilities, perform the appropriate vision testing technique to suit the patient's needs, as well as interpret the results of a patient's visual acuity correctly. So what is visual acuity? It is the measure of the finest detail that can be recognized by the visual system. It can be measured from a very young age using behavioral techniques such as fixing and following a light or an object, as well as by electrophysiology techniques. When a child is old enough to interact and cooperate, clinical measurements can be performed for the visual acuity, which are more accurate. The assessment should be consistent throughout a patient's appointments to detect any changes. So vision development. This begins to develop after birth and generally progresses all the way up until the age of 7 and 8. The stimulation from the environment and the visual stimulus helps to develop the visual system, and this is important for the general development of a child as well. As you can see in the picture, it involves the eye and the cortical areas. So as I said, the system continues to mature until the age of 7 and 8. This period is known as the critical period. So briefly to tell you about the critical period, it's where a period during where new connections are being made in the brain and the visual system. So the system therefore has the most plasticity and therefore the ability to make changes. This period is really important when treating visual dysfunction such as amblyopia or the risk factors that cause amblyopia. Amblyopia has previously been discussed by Dr. Omar in a CME session back in January, so I won't touch on that too much today. You can see in the image here how the vision is becoming clearer as a child is developing, as well as the color vision is coming in as well. So if there's no defects present in the visual system, the vision then can continue to improve progressively. And when a child is said to be around 4 or 6 years old, that's when they say the vision is nearly adult-like. So this table shows the expected average visual acuity depending on a child's age. So around birth, the vision is about 2 to 5%, which then improves to about 10% around 2 to 3 months old, which is quite a significant improvement. Around 6 months old, the vision is about 20 or up to 20%, and then 2 years old at 50 to 60%, becoming nearly 100% or better at 4 years old. So between 2 and 4, the visual acuity doubles. So when to have an eye checkup for children? This is quite a common question that we get in clinic. At the moment, ophthalmologists are carrying out what are called red reflex assessments, which are done soon after birth. During this, they're checking for normal red reflexes and to determine whether there are any structural abnormalities in the eye. Between age 1 and 3 is also a good age, even if there are no apparent problems. Usually we advise this, especially if there are family history of eye problems, so parents having problems or siblings having eye problems. At this age, a child is usually interacting and even communicating, so an assessment can be fairly accurate. And I also recommend having a checkup around the age of 4 or 5, which is prior to starting school, just to make sure that when they start school, they have the best distance vision for their studies. So when you're testing a vision, it's really important to use the correction, and this could be glasses or contact lenses. If glasses, making sure that they are the glasses that they're using for distance, such as TV or driving, and not their reading glasses if you're doing the distance vision. One eye should always be tested at a time, and so covering one up and repeating the vision with each eye, but in some cases you might be required to do it two eyes together. For example, if a patient has nystagmus, you would do the vision two eyes together. The general rule is doing the right eye first, but if there is a bad eye or an eye of concern, generally you would do that one first, followed by the other eye. Patients should be carefully monitored whilst you're doing their vision test. They might be peeking or squeezing their eyes, which would manipulate the visual acuity. They might be using a head posture to help them see better. This is something that should be recorded when recording the visual acuity. And also, if you check the right eye and the left eye, it's really important that you try and use a different set of letters or a different sequence of letters, just in case they might remember what they said before and say the same again. So what are the age-appropriate tests for patients? Between 3 months and 2 years old, or when a patient is non-verbal, you could do a qualitative assessment of visual behavior, which is fixing and following. So you're analyzing the patient's fixation of a target, as well as the ability to follow this. There may be smooth pursuit movements or saccadic movements. You could use small toys or larger toys and objects of light, but ideally without sound, because you're trying not to engage their ears and only their eyes. So the quality of the fixing and the following should be recorded. The other way to test is FPL, which is forced choice preferential looking. So the child demonstrates a preferred fixation toward a patterned stimulus in comparison to a regular playing field. So you're looking at their eye movements, whether they're going towards that stimulus or not. And you repeat these responses to ensure that they're being seen for a positive response. An example of a test like that is Cardiff Acuity cards test, which is what we use in clinic here. They're, as you can see in the picture, they're grey cards with white lines of a picture, and the image becomes harder and harder to see as the visual acuity becomes better, and the image moves from up and down or side to side. So this is tested at 50 centimeters or 1 meter away. Behind the back of the card, it tells you what the acuity is, so you don't have to remember that. And the examiner is sat behind the card, and you're monitoring what the patient's eye movements are doing, whether they're following positively towards the position of the image or not. And the score that's recorded is the last positive response. This can be done binocularly and uniocularly, but I tend to do this binocularly first because it gets the child interacting a little bit better. I find that the vision is better in very small children doing it binocularly, but uniocularly is obviously very important. When performing this Cardiff test, it's really important to try and draw the attention of the child towards the cards. So like tapping on the back of the cards, you could be making sounds. You do have to be very quick when doing this test because the child can become quite bored as well. So you get 3 of each card, so I tend to just do like 1 of 2, maybe miss the size and go back if needed. So that's kind of the technique that I tend to use. I try not to point directly at the picture to guide that child's fixation, but sometimes I might guide it and then change over the card to try and get them to do it themselves. I also have to be really careful that parents are not pointing at the picture themselves, but you do need to get the child's attention a lot of the time with this. I've not only just used this with small babies, but we tend to also use it with patients with dementia or cognitive impairments or stroke. So basically patients who aren't able to communicate or verbalize. If a patient is able to point to the picture or name the image, it's obviously a bit better. It improves the testability and confirms that they can see that image. So when a child is around 3 years old or above, so before school and school age, they should be verbal or showing a level of communication and understanding. So you can modify visual acuity tests and use a subset of letters or symbols or pictures that the patient can identify by naming or even matching. So an example of these tests would be K-Pictures or Sheridan Gardner. Logmar vision testing is more repeatable and a reliable recording of visual acuity. The tests that we have in clinic are symbols or letters that displayed about 4 to 5 in a row within a box to allow for a crowded effect. And you can also reduce this down to a single picture or a letter. The choice of this test depends on the child or the patient's ability and the comprehension. So sometimes if a child gets very bored and distracted, having 4 or 5 pictures in a row can be harder for them and lose their attention much quicker. So sometimes making it a single image, it will be a bit more reliable, a bit more easier. You might get a better idea of what their visual acuity is, and not based on whether they're getting bored. Sheridan Gardner obviously is used when the child is able to name their letters very well. So what I tend to say to my patients is, a lot of them would say, oh, they are very good at their letters, but when I practice, they're a little bit unsure. So I'm not testing their, whether they know their letters, I'm testing what they can see. So I tend to use what the patient is a bit more comfortable and finds easier to do. And also with the K-Pictures, you could do this for a patient with any language. So here, obviously, the children would be saying the pictures in Arabic and even sign language. So K-Pictures is a very common vision test that's used for not just 3 years and above. Even adults have used it, again, with patients with learning disabilities. So that's this is a K-Pictures. This is actually an old image because K has modified this and updated the symbols to include some different ones. But currently in clinic, we tend to have, actually in Moorfields, we have this version, but in Donat, we have the newer version because this one is not available anymore. So like I said before, K-Pictures, singles or crowded, can be used for any age. Singles for children who have, or patients have limited attention span. Singles is not very ideal for patients who are having treatment for amblyopia because the vision is overestimated. But sometimes this is necessary due to concentration. And like I said, you can use matching cards if they're not able to say all the names properly, or sign languages, or any kind of language. So for adults, you generally tend to use a crowded chart, which is a little bit more reliable. It could be Sheridan Gardner letters, which is in the picture here, that kind of subset of letters. It could be the tumbling E's or the C's, so the patient would then show the direction of the symbol with their hand or verbally say left, right, up, down. This is quite commonly used here as well with patients who speak Arabic and not very familiar with their letters. So in terms of scoring visual acuity, it should be tested to the threshold, which means all the way until the patient can no longer distinguish the letter or the picture, basically until the end of the test. This will help pick up on changes to the vision and make it more repeatable. Quite commonly, some people will test just until 6x6, but maybe if they test all the way till the end to 6x5, and then if a patient is complaining that their vision's reduced, but you've only tested 6x6, you won't be able to pick that up. But 6x6 or 0.0 or 20/20 is usually described as what is normal vision, but many people are able to achieve better than this. When you're recording visual acuity, it's really important that you record each incorrect response and not round up the vision to the nearest line. And here is a picture of an occluder with a pinhole. So vision, if it's less than 6x6, is usually rechecked with pinhole to see if there's any improvement in vision. So if we're testing children the tips that I have for testing children is to carry on even if a child has got an answer wrong. You can always go back to it and correct them. I just find that sometimes if you tell a child they're wrong, they get a little bit quiet and they don't want to answer anymore. You need lots of enthusiasm, lots of encouragement for children as well. They tend to give up easily, so you have to try and push them to the limit and also be fairly quick. I tend to start off slightly big to get their confidence and then skip lines again for speed. I allow the patient, so I tend to practice the pictures with them first, so just to see what they have, what they name these images, or and making sure that they know the letters well. So whatever word that they use, I don't try and correct them and teach them the right one. If that's what they say, as long as they consistently say that every time they see that picture, it's still a positive response to the vision. I also try not to give hints, and it's really important to tell parents not to do this as well. I know some of the orthoptists, if they're on here, or anyone else that checks vision for children, you might see parents saying, "Oh, what did you have for breakfast this morning?" Because it's the picture of an apple, which, that's not the point of a visual acuity. So it's really important not to give them any hints, but just encourage them to give an answer. So if we go to Logma vision scoring, so I know I've done some training with some of the nurses in Health Plus, and on the system that we use, which is a Thompson chart, it has the option to score your vision automatically for you. But right now I'm going to talk about how you can do it without using the Logma scorer, because sometimes it's not quite correct in terms of the transition to Logma to Snellen. So each picture or letter, which is known as an octotype, it has a value. So depending on how many there are in a line, commonly 4 or 5, they would have a score basically. So if there's 5 in a line, each picture has a score of 0.02. If it's 4 in a line, it has a score of 0.025. And as you can see, so if you add 0.02 5 times, it makes 1. So you'll get the whole of the line. So every incorrect response, this number is added to the logma score of the whole line. So if we'll go on and explain it a little bit better with having a line and how to score this, but basically a higher number shows poorer vision. So any number that's closer to 1 has poorer vision. So the total acuity score will equal the logma score of the line if they are all correct. So if I go on here, so here is an example. So you can see, if you can see the picture, you can see 0.2, 0.3, 0.4. So if you're testing on a 0.3 line and there's 5 pictures and only, say for example, 3 of them were correct, the score would be 0.34, because you add the 2 incorrect scores to the 0.3 line. So 2 lots of 0.02 and 0.04. So you add that to the 0.3 line, because that's the one where they got a couple wrong and the top line was right. At this point, I hope I haven't confused anybody. If you have any questions, you can raise your hand. But we are going to practice this next. So before we have a go, does anyone have any questions that they want me to clarify? Because we're going to have a go, and it'd be nice if everyone could give their answer. Okay, so I'm going to go ahead and we're going to practice doing some scores. So this is a 0.3 line, and a patient has got 2 incorrect responses. So they've only got 3 of those pictures right. Does anybody have an idea on what the score of the visual acuity would be here? Anyone? Okay, so the score would be 0.34. So I'm going to move on to another example. So this is on the 0.09, sorry, the minus 0.1 line. The patient has got one incorrect response on that line and all the rest are correct. Does anybody know what the score of this would be?
Hi, Sonal.
Leah.
So if it was one wrong on the minus 0.19, you would get minus 0.8.
Yeah, that's correct. Thank you, Leah.
No problem.
So that would be minus 0.8. As Leah said, you add the 0.02 to that minus 0.19. I mean, this one's not as complicated as it looks, but you can see the patient's got one incorrect on those three lines. So I can go through this. Does anybody have an idea of what the score would be? Feel free to unmute and answer if you know. Otherwise, I'm happy to give the answer. So the score would be 0.16. Because you have to kind of bring those forward, if that makes sense. So take off the 3 from the bottom line, make it easier, and then you have your score. Here's another one. The score of this would be 0.24. And these last ones, which are fairly easy. So the first one would be, because remember there's 4 here now, not 5. So the score would be 0.075 and minus 0.075. So thank you, everyone. I hope that was helpful to you. If there's any questions, please feel free to ask. You can write it in the chat box or unmute and I'll answer them.
Hi everyone, if you have any questions for Ms. Sonal, kindly unmute yourself and you can ask her directly, or you can post in the chat box. I can ask it for you. Also, the links for the posters and the evaluation surveys are posted in the chat box. Kindly complete the surveys as well.
Sorry, as Annette said, the post questionnaire surveys posted in the chat box, as well as the evaluation forms. If you can complete both of these, that will be really helpful for our future CME sessions.
Hi everyone, if you have any questions for Ms. Sonal, kindly unmute yourself and you can ask to her.
That was great. Thank you so much, Sonal.
Thank you, Leah.
Sonal, we do have a question from Dr. Anusha. She asked, is there any education you are imparting to patients after the testing, and if so, what kind?
In terms of education, I'm not sure, sorry, what you mean, but if I ever see a patient or parents with a patient of a very young age, I might give them some advice on what things to look out for if we're expecting that child potentially to have any visual problems. So, for example, we might see a child at a very young age, might have done a refraction on them and notice that they might be becoming short-sighted, for example. So in that case, I would tend to give advice to parents on what things to look out for if the patient is struggling. So for example, are they spotting birds or planes in the sky, or are they missing them? Small objects on the floor? Are they wanting to get really close to the TV? You know, those sort of things I tend to advise on. And sometimes I give them copies of K pictures to practice. So especially with like children with learning developmental needs and special needs, then I might give them pictures of Ks to practice with and get comfortable with and learn them. So when they're ready, we can do that in clinic. I hope that answers your question.
Yeah, she's answered great. I hope that clears the question. Dr. Betul says thank you. And hi everyone, if you have any further questions, you can kindly unmute yourself and ask Ms. Sonal. In the meantime, kindly complete the surveys as well.
So
Okay. Yeah.
Oh. So if there's no more questions, I just want to thank you all for attending today's session. I hope it's been really helpful. And if anybody has any questions going forward, even I know that the Thompson chart has been installed in some of the departments in Health Plus. So I've done some training for some of the nurses already. But if there are any questions in using this, please drop me an email and let me know, and I'm happy to help. Thank you again.
Thank you, Sonal, for the meaningful section. Thanks everyone for attending, and see you for the next section.